Hello and welcome everyone to tonight's webinar entitled PrEP in Practice, the role of primary care in HIV prevention. Tonight's webinar is brought to you by Capital Health Network and the Australasian Society for HIV, Viral Hepatitis and Sexual Health Medicine. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and I pay my respect to their elders, past and present. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. I'm Dr. Leonie Harcourt, a GP Education Advisor at Capital Health Network. Also with me tonight is Kanal Mohiti, the Events Lead at Capital Health Network, and of course, our three expert speakers. Neil Steitzel, a Project Officer at ASHM. Neil works on the PrEP project. GP Dr. Clara Tak-Ming Soo, and Nurse Practitioner Shannon Woodward. Clara is the current practice principal of East Canberra General Practice. She's been an HIV S100 prescriber since 1996, and she works closely with the LGBTIQIA+ community. Shannon has been a nurse practitioner at Canberra Sexual Health Centre for 16 years and is an HIV S100 prescriber. She sees patients every day for PrEP and has an interest in STI and bloodborne virus biomedical prevention. So now we're going to multitask. I'll run through the housekeeping, but there's also going to be a poll that appears on your screen about your confidence with prescribing PrEP. So please answer the poll while I continue to talk. And our panelists are very happy for you to type questions into the Q&A box of your Zoom window. So not the chat box, but the Q&A box, and they'll endeavour to answer the questions throughout the presentation. But we will also have a Q&A section once the presentations have finished before we move on to case studies. So there's also a chance for discussion then. All participants have been muted, so to communicate through the Q&A box. The presentation itself will be uploaded onto the Capital Health Network YouTube page, and that'll be in a couple of weeks, and you're welcome to share it with your networks. With respect to CPD, please fill in the post-event evaluation survey that will appear as a QR code at the end of the presentations tonight. And CHN will email you a certificate of attendance, which you can use to self-report 1.5 hours of educational activities to your CPD home. Also, before we start, just to flag the Health Pathways website, which has up-to-date guidelines and advice and referral pathways for topics such as PrEP and PEP. And the generic login is the word together, all lowercase, and the password is forhealth, FORHEALTH, also all lowercase. So now over to our speakers. Thank you very much.
I'll just give you a little bit of information about ASHM. ASHM's the peak organization of health professionals in Australia and New Zealand working in HIV, viral hepatitis, and sexual health. We do policy development and advocacy. We deliver education focused on prevention, identification, management, and treatment of bloodborne viruses and STIs, including the HIV and hepatitis S100 prescriber courses. And we develop guidelines and resources, including for PrEP, which have all just been freshly updated and are available on the ASHM website. So yeah, I'll hand over to Clara and Shannon to give you your PrEP webinar.
Hello, good evening, everybody. I'm Dr. Clara Tak-Ming Soo, and as Dr. Leonie Harcourt mentioned, I actually work in Canberra, and I've actually been working in the HIV area for a pretty long time. So the learning objectives for tonight are up there. So we're going to describe HIV epidemiology in the ACT, because that's where Shannon and I are based, and in Australia, and different HIV prevention strategies. We will explain the different dosing options for PrEP dosing. We'll provide patient education on the effectiveness and appropriate use of PrEP. And also, Shannon will be going through the PrEP decision-making tool to help manage patients on PrEP. Okay, so some background about HIV in Australia. So as you can see on the slide, about 30,000 people are estimated to be living HIV in Australia, and that's at the end of 2023. But unfortunately, of that number, about 2,360 people are unaware that they're HIV positive. As you can see, from the chart there showing new notifications for HIV, the numbers have gradually dropped since 2014. There were in 2023, which is the last year that we've got on the chart there were 722 HIV notifications with the first ever diagnosis in Australia. And that represents a 33% decline in notifications since 2014. Now you can see that big dip in 2021, 2022, and that's we probably attribute that largely to COVID, actually stopping reducing a lot less sexual contact between people. We do know that 80% of HIV negative gay and bisexual men who had casual partners were regularly using at least one strategy to protect themselves against acquiring HIV, which is an increase from 69% in 2014. And a lot of the increase is actually due to the introduction of PrEP. So PrEP actually went on the PBS from the 1st of April 2018. Prior to that, PrEP had actually been available in large-scale so-called trials in a lot of the large metropolitan centers. And up until the end of December 2023, about 74,500 people had ever taken PrEP. Now, we do know, from studies that have been done that most HIV transmissions still occur where one partner has PrEP, has HIV but does not know it, and therefore, using PrEP in sexual encounters with people whose status you don't know obviously still has a significant protective effect. And Australia has adopted a virtual elimination target of HIV, and that involves reducing the transmission of HIV by 90% from 2010. So we got a little way to go yet. So in terms of who actually gets who we get new diagnosis of HIV in, 63% of new diagnoses are still in MSM. There's men who have sex with men in 2023. In 2023, heterosexual sex was reported as the key risk factor for 205 diagnoses. 37% of HIV notifications, unfortunately, were classified as late diagnosis in 2023. And the definition of a late diagnosis is somebody who has a CD4 count less than 350 or has got an AIDS-defining illness at diagnosis. And that usually indicates somebody who's actually been HIV positive for a while, at least for a long enough period of time, to sustain damage to the immune system. And we do know from those statistics that late diagnoses are higher in people who are born outside Australia who have come to live in Australia. So in Oceania, excluding Australia, where 58% of diagnoses were late diagnoses, in people from Southeast Asia, where 54% of new diagnoses were late diagnoses, and 53% in people in sub-Saharan Africa. But obviously we know that there are all sorts of cultural, social, and economic factors why people may have late diagnoses. Next slide, Shannon. So the 9th National HIV Strategy, which is what we're actually working from now, aims to virtually eliminate HIV transmission in Australia by 2030. So we want to actually try to reduce the numbers of new diagnoses further. And that's where you all come in, where because PrEP will be a key plank of that strategy. To sustain the virtual elimination of HIV transmission among people who inject drugs, among sex workers, and by vertical transmission. So obviously we use different strategies in those areas. Needle syringe programs have made a big difference for people who inject drugs, and for vertical transmission, testing of prenatal testing for HIV has made a big difference. We want to reduce the morbidity related to HIV, and so part of that would relate to not only preventing infection, but also trying to get diagnosis earlier in the illness, so that we can reach people and we can actually treat them before they become too ill. And obviously, part of the strategy to encourage people to actually get tested is to eliminate the negative impact of stigma, discrimination, legal and human rights issues on people's health. We want to minimize the personal and social impact of HIV on health and well-being by early diagnosis and early treatment. So in terms of HIV prevention, there are many different arms of HIV prevention. For the first arm is treatment as prevention. And what that means is that we now actually aim to treat people as soon as they're actually diagnosed. Many trials have shown that there's no benefit in actually waiting, waiting just gives an opportunity for more transmission and for the virus to actually cause damage to the immune system. Post-exposure prophylaxis, which is administered through state and territory programs, aims to actually treat people who might have an at-risk exposure. Pre-exposure prophylaxis is what we'll be talking about today. Condoms and other sexual behavioral strategies, needle and syringe exchange programs, which are particularly useful for people who inject drugs, and the prevention of vertical transmission, as mother-to-child transmission. Now, on the other part of the slide, you can see that diagram there about U equals U. And U equals U stands for undetectable equals untransmissible. And this is part of the strategy to try to reduce stigma around HIV. And what it means is that research has clearly shown that in someone who's been on treatment and has been on treatment for more than 6 months and has an undetectable viral load, that they cannot actually transmit HIV by sexual means. Now, that applies to sexual transmission. The evidence is not quite so clear for injection. Okay. So in terms of numbers, you can see from the chart there that the numbers are still gradually increasing. So if we look back from the start of PrEP going on to the PBS on the 1st of April 2018, we've now got a cumulative total of more than 80,000 people who've actually been obtained at least one script for PrEP. In the past 12 months, 47,000 people have obtained at least one script for PrEP. And in the past 3 months, that number is 27,000, just about 27,000, 27,500. Now, 3-month figure, is relevant because the scripts for PrEP rewrite, if they actually used continuously, would last for 3 months. So that gives us a bit of an idea, of people who may actually be on continuous PrEP. Next slide, Shannon. How do we know that PrEP works? Well, there have been lots and lots of trials, looking at men who have sex with men, heterosexual adults, and injecting drug users. And for participants who took their PrEP every day, and that meant 100% adherence, PrEP was 95 to 99% effective. In those studies, transgender people haven't been well represented, but the data that we have from one of those trials, the IPREX trials, suggests that PrEP is effective in transgender people if taken correctly. For cisgender men, on-demand PrEP rather than continuous PrEP is an alternative regime that can be recommended based on a few provisions. And Shannon will talk later about how we actually prescribe on-demand PrEP. In terms of long-term safety concerns related to PrEP, it's mainly, so when we talk about PrEP, we're mainly talking about a combined tablet that contains tenofovir disoproxil and emtricitabine. Emtricitabine seems to be very, very benign. So the safety concerns that we have are mainly related to the tenofovir component. Tenofovir disoproxil can be related to a development of renal dysfunction. It can cause a Fanconi-like syndrome. It can happen in about 5 to 10% of the population if they're on the PrEP for a long enough period of time. So that's one of the things that we do monitor when someone is actually on PrEP treatment. Similarly, tenofovir can also lead to reduction in bone mineral density, again, because of its effect on renal function. Tenofovir and tricitabine have activity against hepatitis B. But what that means is that if someone's got chronic hep B and they actually stop using the PrEP for any period of time, that can actually lead to a flare in their chronic hepatitis B. So that's an area where we actually have to give special advice to people if we find that they also they are actually chronically infected with hepatitis B. Development of antiretroviral resistance in people taking PrEP is very, very rare. Most of the cases have actually been happened in people who were actually serial converting prior to, during that time when PrEP was actually being introduced. Sorry, am I supposed to? Oh. Okay.
Next slide.
Okay, next slide. When might you actually recommend or institute PrEP? So it can happen if a patient comes to see you or if a clinician suggests it. So the question there, is that why might the patient request PrEP? Now, as it says, people who present requesting PrEP are typically at high risk of HIV, and I would actually have a very, very low bar to actually prescribing PrEP to someone who actually requested, provided they understand the risk involved and they actually give informed consent and they actually get given the right instructions for how to actually take the PrEP. Because I think what we perceive as a risk, is dependent on the information that we actually have. And given that sexual behavior is an area that still carries a certain amount of shame and stigma, people can actually be reluctant to actually disclose their full spectrum of risk to a health professional, especially if someone they don't really know that all that well. I mean, would you agree with that, Shannon?
Yeah, definitely. Yeah.
Now, obviously, as a clinician, if you have actually elicited a history of high-risk behaviors, or you actually diagnose an STI suggesting that the patient is actually engaging in high-risk behaviors, something like, diagnosing rectal chlamydia, for example, that could be another situation where you could initiate a discussion with the patient about going on to PrEP. Anything you want to add to that, Shannon?
No, we tend to at our clinic now, we used to strictly follow guidelines, but anyone who asks for PrEP, we provide a script. And well, if they're in a risk group, which we'll go through, and we recommend PrEP to any of our patients with a rectal STI or syphilis. Yeah.
So key populations for PrEP take-up. So these are the priority populations identified for testing in the 9th National HIV Strategy. So gay men and other men who have sex with men, Aboriginal and Torres Strait Islander people. And I should add, the indication for testing for HIV among Aboriginal and Torres Strait Islander people highlights an enduring traumatic legacy of colonization, recognizing the historical disadvantage perpetuated by institutional racism and systemic failures that collectively contribute to health disparities between Aboriginal and Torres Strait Islander peoples and non-Indigenous Australians. Another group will be people from high HIV prevalence countries and their partners, travelers and mobile workers, because they have more opportunity to have actually sex when they're actually traveling, sex workers, people who inject drugs, people in custodial settings, and trans and gender diverse people. Around the world, trans and gender diverse people are a group that has some of the highest prevalence of HIV positivity. Next slide.
Thank you, Clara.
So Shannon, hand on to you now.
Thank you very much, Clara. So I'm going to go through some of the steps in prescribing PrEP and use the ASHM PrEP decision-making tool to do this, which is readily available on the ASHM website. And it's fantastic when you're starting out prescribing PrEP, or even if you're an experienced prescriber, it can be really useful in clinical practice. So,
Excuse me, and Shannon, I might just quickly interrupt because there's a question here.
yeah, sure.
So someone has actually typed the question: do you prescribe PrEP before seeing the HIV negative test? If that's the case, is it on a private script? I think Shannon will answer that when she goes
Yeah.
through the steps, but the short answer is no, you have to have an HIV negative test first.
Yep. So we'll cover that, and that's described in this tool. So this is the front page of the PrEP prescribing tool in Australia. So you'll see up the top, PrEP can be prescribed by all medical practitioners and nurse practitioners using PBS scripts. No specialist training is required. And we see that a fair bit in our clinic. Someone might refer a patient to our service because they feel that because these are antiretroviral drugs, they have to be prescribed by an S100 prescriber. But PrEP is listed on the PBS as a S85 drug, so anyone, any doctor or nurse practitioner can prescribe them, which is fantastic. So step one, what we have here in this prescribing tool is behavioural suitability, and that covers on what we've said in that patient requests PrEP, or you might see a patient that you think could benefit PrEP, and then you can move along to box number 2, 3, and 4, which we will go through separately in a minute. And then on the back page is a risk. So if you see a man who has sex with men in your practice, for example, you can go to their box on the back of the tool and see if they fit into any of those high-risk groups, or a heterosexual person as well. So it has definitions of the back of high-risk population groups. It's got a box on patient education, how to stop PrEP, and then the ongoing monitoring. And as I said before, the tool is great and really helps. So we'll go back here. So if we look at behavioural suitability, so say you have a patient come to you in your practice and say, I want PrEP, and they might say, I have sex with, they might be a man, and they say, I have sex with men, I want PrEP. You can then look at whether they're clinically suitable by going to box 2. If you're unsure if they're suitable, you can flip over the chart to the back and have a look at whether they're suitable or not. So we would look at clinical suitability. So first step there is we want to confirm their HIV status and review their medical history, including their renal function. I must say at our clinic, we've learned a lot about renal function as a specialist sexual health clinic since PrEP's become so widespread. So it certainly can be a factor, but we've hardly told any, we have nearly 500 patients on PrEP, and I don't think we've told anyone to stop taking it. So there are workarounds, which we'll cover a bit when we talk more about renal function. So the first step there is we want to make sure someone's HIV negative, okay? And ideally we would like to start them on PrEP if they've had a negative test in the last 7 days, but not everyone can access testing or services. So we would like to make sure that they've had a negative test at least in the last 7 days. Okay. Now, what we tend to do in our clinic is we're fortunate and a bit luckier than some GPs because we take blood in our clinic. So we collect the blood, give them their script, and then we can recall them very quickly if we get a call from the lab with a positive result. I don't know how you work that into general practice. Dr. Meng Su, do you wait for results before you would send a script, or how do you work around a HIV, waiting for a HIV test?
I guess what I tend to do is I tend to talk to them about sexual exposure.
Yep.
So they've actually had a recent sexual exposure, and so there's a risk that they might be in the window period. Then I think that avoid them having to come back. I probably would actually give them a script. But I'll
Yep.
say but please don't take this until
Yep.
I've actually had the test result, and then I'll
Yep.
contact you about that.
Yep, sure, great. So we normally would have our results back that afternoon or the next day because we've taken their blood in the clinic, but we would say the same thing if we didn't take their blood for whatever reason. So we want to make sure we ask all our patients if they've got any signs of an acute HIV infection. For example, fever, night sweats, fatigue, myalgia, arthralgia, rash, headache, pharyngitis, etc. And if they do, we would ask them further about, when was their last sexual exposure? Did they know that person? Have they had a URTI or anything else like that? But it would not stop us probably from proceeding because they're there in the clinic. We would do renal function testing. So we want an eGFR of at least 30. Okay, actually, if we're prescribing tenofovir, disoproxil, fumarate, we would like an eGFR of at least 60 mils per minute. But if someone had a low eGFR and desperately wanted to have PrEP, we would talk to them about an alternative, which is tenofovir alafenamide as PrEP, which patients have to import from overseas, and I'll cover off that a bit later, but that's absorbed better into the cells rather than plasma, so it's not so nephrotoxic. Okay.
We got another question here, Shannon. So this question says, most of my patients who ask for PrEP have had their PrEP started by another person elsewhere or who are not regular patients. Should I insist on the HIV test or trust their self-report of being HIV negative? I think what I would normally do, is to, I think as we discussed, is to say, well, as part of going on PrEP, and you cover this as well, we would, and especially for a new patient, I would probably talk about doing a full STI screen, and renal function. So I'll get them all to have that blood test, give them their script, but probably say, when the results come back, usually in the next day, I'll give you a call to confirm that you're HIV negative and that you are and that your renal function is not a problem, and then you can start your PrEP. And so really, there's just a 1 day gap really in my general practice, usually between my prescribing the script and then starting on PrEP.
Yes. We would very, very rarely, if ever, give a PrEP script without a HIV test, unless someone's lost their repeats, because we still have paper scripts. So yeah.
But in your case, Shannon, I think you give the script and do the test, and you have the result late in the afternoon, so you then contact the person.
Yes. Our lab would call us straight away.
Yeah. So I think neither of us would actually just give a script and not do a test at all.
No. So we want to make sure that the person is HIV negative, and then we'd actually like to see when their most recent exposure was, their most recent high-risk sexual contact, so condomless anal sex, because they may be eligible for PEP or post-exposure prophylaxis if it was within 72 hours. So we're very lucky here at a sexual health clinic. We have PEP in our cupboard. So if someone came in wanting a PrEP script and they had sex the night before, we'd start them on PEP, which in most cases is the same drugs as PrEP, tenofovir and emtricitabine, 1 tablet daily. So we are starting to see a number of patients now who have had PrEP before and might have a box at home and will start themselves on PEP, or we're seeing sometimes patients who might come in for follow-up bloods after starting on PEP at CARMS or by their GP in the community, because these are the same medications. And if someone can't get into the sexual health clinic or has an exposure on the weekend and doesn't want to go to emergency department and wait for 6 hours, and your practice is open, they could turn up and ask for PEP, which some GPs are starting. Has that been your experience, Clara?
Yes, previously, I think before PrEP came along, we actually had to send everybody to you to actually get PEP. But now that PrEP's on the PBS, it's often easiest for us to just say, look, we'll just prescribe you this, But obviously, we have to get a history to make sure, that that person hasn't got a high-risk exposure and actually needs, a 3-drug regimen. There's another question here from somebody who said, can you, oh, sorry, the question sort of vaguely disappeared. But the question was saying, why do we have to wait for an HIV negative test result? And the reason is because if someone's actually HIV positive and we just treat them with the medications we use for PrEP, that doesn't actually give us sufficient control of the HIV virus. You generally need to have a 3-drug regimen to do that. And because this is just a 2-drug regimen, it's good enough to prevent infection HIV, but not good enough to treat HIV. So if we just use this within a fairly short period of time, the virus will develop resistance to medications.
Yep. Great, thank you. And there is a question there too about how long it takes in regular pathology for the test to come back. So I'm talking about a public lab there. We would get that done the same day. What about in some of the private labs? How soon do you get HIV results back?
I'm usually getting them quite quick,
Yeah.
like 24 hours or so. Yeah.
Yeah, great.
Yeah.
Okay.
And there's another question, sorry. I missed the part about how recent the HIV test needs to be before starting PrEP.
Yep, sure. So that's on our box here in clinical suitability. So we want to confirm that the patient's HIV negative, ideally within the last 7 days. But for people who cannot easily access HIV testing within the past 4 weeks is okay. Okay, so back to our number 2, clinical suitability. So we've talked about PEP and how people can access that. And ASHM have a fantastic new PEP decision-making tool, a bit like this that you're looking at here, but it's all about PEP and risks and what to prescribe and where people can get it. So that is on the ASHM website as well. Which is really helpful, and we use it all the time, and it's actually really great to go through with patients as well. So obviously if someone is, if you get a positive result, they're not suitable for PrEP and are referred to a S100 prescriber for HIV treatment. And there's a good prescriber map on the ASHM website as well. So what other testing would we need to do at the time? So we've done a HIV test. We would like to assess this person for STIs and viral hepatitis. So hepatitis A serology, if they're a man who has sex with other men, or someone who has sex with men who have sex with men, and vaccinate them if they're not immune. Hepatitis B, we would like to vaccinate if not immune, and we're going to do a surface antigen, surface antibody, and a core antibody. And confirm the immune response a month after the last vaccine, because there still is 5 to 10% of the population, more common in men, who don't respond to the vaccine. So we would like to try and get those people immune. And of course, if they're Hep B surface antigen positive, we would refer them to a Hep B specialist. Again, another prescriber map for that. And there's a Hep B decision-making tool as well as on the ASHM website. We'd like to do Hep C serology and treat them if an incidental Hep C infection is picked up. And then we want to do the STI screening. So that's as per the STI management guidelines, which I'm sure you're all familiar with, which is a fantastic tool and really user-friendly and intuitive. We want to look for, if we've got a man who has sex with men, we want to look for infectious syphilis, gonorrhea and chlamydia. And we really want to look at chlamydia and gonorrhea at all sites. So throat, anus, urethra. And for people of childbearing potential, a pregnancy test. So we can order all those tests at the time of the HIV test. And then based on whether people need vaccinations, etc., we would retest as per the tool on the back. So then we can prescribe PrEP, and we want to look at the dosing schedules. And we do, I'm happy to talk about them now in line with our tool. There are some slides on them, but we can flick through them as we come to them too. So we've got a couple of options here. We've got daily continuous PrEP, which is suitable for anyone with an ongoing risk of HIV. And it says there, start 7 days before the HIV risk exposure. So that's dependent on whether it's a heterosexual woman. Now, if we're starting a gay man on PrEP, we will tell them they can take a double dose to start PrEP at least 2 hours before they plan to have sex, and then continue daily, and they'll be covered. And you can prescribe tenofovir disoproxil 300 milligrams and emtricitabine 200 milligrams. Comes in the one tablet daily, 30 and 2 repeats on the PBS. So it says there, you can see a note, patients with an EGFR between 30 and 60 mils per minute are only suitable for PrEP as tenofovir alafenamide and emtricitabine. And that's the tenofovir alafenamide. The alafenamide is a different component of PrEP. And as I mentioned it before, it's picked up, its cellular uptake is much better than tenofovir disoproxil, and it's a much more stable drug, and there's less levels circulating within the plasma, so it causes less renal side effects and less bone side effects. So it can be somewhat a safer, more steady alternative to tenofovir disoproxil. However, it's not on the PBS. It would be very expensive if it was to be purchased from a chemist within Australia. We have a number of patients on it, mostly because of reductions in the EGFR. And these patients will write a prescription for them, a private script for 90 tablets, and they will self-import it through one of the overseas pharmacies. And there's a whole website dedicated to that called PAN, or PrEP Access Now. And most patients will import it through Green Cross, which I believe is Indian-based. And it will cost them about $120 Australian for plus postage for a 3-month supply. So it's not much more than what they'd pay if they were paying $31 anyway. And a lot of patients are able to do that. So that.
And just to interrupt, Shannon, I got another question. So how often would you do an HIV test in a person on regular PrEP? I would normally do them when they come back every 3 monthly for their script.
Yeah, and we've got that on the back of this tool too, which we'll cover. Yeah, we would do it then as well. Unless, Rosalie, they've had an exposure within, if they're starting PrEP and they've had, say, a high-risk exposure 2 weeks ago, most of the time our HIV antigen antibody tests in Australia will pick up a positive result within 2 to 4 weeks. So we'll often say to a patient, if they had a high-risk exposure in the last 3 weeks, we'll get them to come back at 4 weeks to do a repeat window test, and then at 3 months as well. So our other option for taking PrEP, and yes, we will share the overseas purchase details. I'll make note of that because it's really helpful for patients, especially patients who think that they've got to come off PrEP because their EGFR's dropped to 50. And we don't want those people who are at high risk to contract HIV either and have an EGFR of 50. So tenofovir alafenamide is a really good option. So then we've got on-demand PrEP, and this is the 2-1-1 method. And this is taking a double dose, so 2 tablets, 2 to 24 hours before sex. So you do have to predict when you're going to have sex. And and then 1 tablet 24 hours after that double dose, and 1 tablet 48 hours after the double dose. So this is suitable only for people assigned male sex at birth with HIV risk from sexual exposure, who are not using estradiol-based hormones, do not have chronic Hep B with liver cirrhosis. So the ASHM have updated their PrEP guidelines just last month in August, and there is a little bit of a new information on people with chronic Hep B, which the World Health Organization now does say that people with chronic Hep B who are not cirrhotic and have a viral load of less than 2,000 can have on-demand PrEP as an option, but daily is preferred. But it's felt that people with Hep B have really missed out on the PrEP uptake for that reason, but there is that option as well in the guidelines. and they don't have renal impairment. So we have a lot of patients on on-demand PrEP. And that might be suitable for people who might only have sex once a month, or just don't feel they need to take it every day. And it's also in here, we've got daily and on-demand, and there's also people that might be going overseas on holidays and might want to take PrEP while they're overseas. And it's quite safe and suitable to take for a month at a time, and then, only that time of the year. But on-demand PrEP is used by a lot of people. And you would prescribe, so we prescribe tenofovir, disoproxil, 300 plus emtricitabine, 30 tablets, and our clinic actually prescribes on-demand PrEP. We only give one repeat. Maybe we're a bit stingy, but that way we find people keep coming back. And you can prescribe 2 pills 2 to 24 hours before sex, 1 pill 24 hours later, and 1 pill 48 hours after that first dose. If someone then keeps having sex, they just continue with 1 pill daily until 48 hours has passed. So you can see it there.
Got a couple of questions, Shannon.
Sorry. Yeah.
Yeah, sorry. So
Yep.
the first one from Stephen Wu: should I test sexually transmitted infections, EGFR, and any other blood test in the same way as HIV testing? That is within the last 7 days or last 4 weeks with your test before starting or continuing PrEP.
That would be fine, I would think. Clara,
That'd
would
be
you
fine.
agree?
Yeah.
Yeah.
I mean, so there is, I think actually ASHM is actually looking at the STI guidelines, so that might change in the future.
Yeah.
But the thing about testing, in someone who's actually using continuous PrEP, they'll be coming back every 3 months. So we're already testing them every 3 months, and that fits in the current guidelines that says that if people are actually having casual sexual partners and the MSM, we really should be checking them for sexually transmitted infections every 3 months. So that would fit in with that. Now, if they come in less frequently, then I guess we just test them a bit less frequently. Because it means that they're probably using on-demand PrEP. They're not actually having quite as many sexual partners. We certainly wouldn't chase people and say you have to come in every 3 months and get your test.
No. And we'll sometimes see patients who are on daily PrEP or on-demand PrEP that we haven't seen for a year.
That's right. And then the second question is the overseas purchase of medications considered legal officially? Yes, it is. Yes. Yeah. So you are actually allowed to purchase and import medications for your own personal use as long as it's not a controlled substance.
Yeah. And I think that you can only import 3 months, and all those rules are on the TGA website, and it must be on a script by an Australian registered medical practitioner. So a nurse practitioner technically can't write a legal script for that.
Okay.
So you can see notes on prescribing PrEP down in that little box. It can initially be prescribed on the same day as a HIV test. Advise the patient ideally to start PrEP within 7 days of their HIV test. It's PBS listed for people who have had a negative HIV test no older than 4 weeks, or that a HIV test has been conducted with a result forthcoming. It's a restricted benefit, and patients also. So PrEP now is quite reasonable. You can buy it. It's on the PBS obviously for $31.50 or whatever the PBS price is, and $7.60. At some of the cheaper chemists, it's only about $22 a box. So on a private script, if you saw a patient who is Medicare ineligible and they wanted to go on PrEP, they could either import it from overseas, but it's just the same price to go to a cheaper chemist and get it for $22 a box per month. I found out the other day that I'm sure a lot of universities do it. Australian National University, their student union covers the cost of PrEP and some other medications for students. And Meridian in the ACT, the old AIDS Action Council, they can provide a voucher scheme that people can use on that online website. And that's about PrEP for everyone. So even if people have no money, they can self-import PrEP with a voucher at no cost. Okay, so we'll go on to the next slide, which is the back of this chart. So we've talked a bit about these already. So we've got the HIV risks up in the top, and it says there that list is not exhaustive. So once upon a time, we used to be really strict about who we wrote PrEP for, but we've learned that not every patient tells us the truth. And if we, we would not like to deny anyone PrEP who then might contract HIV. So we've got our men who have sex with men and trans and gender diverse people there. So receptive condomless sex, regular condomless sex with a person living with HIV who's not on treatment and or has a detectable viral load. So as Clara mentioned earlier, U equals U is a good HIV prevention measure, but and most people nowadays are on treatment with a undetectable viral load, but we still have some patients who are on PrEP despite that, and we do prescribe it for partners of people living with HIV who are on treatment. A rectal STI or infectious syphilis, and shared injecting equipment with a person living with HIV or with men who have sex with men of unknown status. We've then got some information on heterosexual people. So heterosexual people who have condomless sex with any casual man that has sex with men. Again, someone with HIV with a detectable viral load and shared injecting equipment. So I think we've covered that. The patient education, condoms and regular testing, safe injecting, ongoing monitoring every 3 months. And you can see down the bottom, there's a box of what to do. So ideally, this indicates that people should have a HIV test about 30 days after initiation. You can see there that that's optional, and that depends on where their last exposure was, and assess side effects. And then you can see the testing that's done at 90 days and every 90 days after, and then the 6 monthly renal function testing, urine protein creatinine ratio every 6 months, annual Hep C serology and Hep B serology as needed. And we've got a box there on how to stop PrEP, because people will go, oh, do I have to stay on this forever? No, they don't. So for cisgender men and other people assigned male at birth who aren't using estrogen, they can stop 48 hours after their last exposure, so after 2 tablets. And other patients on daily PrEP should continue PrEP for at least a month after an exposure. And patients who do stop PrEP might have to need a plan to restop PrEP if their risk increases again. And sadly, we've had some new HIV diagnoses by patients who've been on PrEP, but then have stopped it for whatever reason and contracted HIV in that time. Okay, so I think we've talked about post-exposure prophylaxis. Of course, that's after an exposure, and that reduces the chance of infection taking hold. And we don't have any good data on how effective post-exposure prophylaxis is, but we do on PrEP, which is ideal and much more effective than post-exposure prophylaxis. So we've talked about HIV status. We've talked about PEP. So PEP, of course, is taken within 72 hours. The first 24 hours, it is most effective. That's why we've got the sooner the better there. So if you do see someone who comes into your practice and wants to start PrEP, and you find out they've had condomless anal sex 2 days ago, you may have the confidence then to give them a script for PrEP and tell them to start it as PEP, and that will be very effective, assuming that they haven't had sex with someone with HIV, as Clara mentioned before. And we transition a lot of people from PEP to PrEP. So we'll see them we ask them to come back on day 28 of their PEP, and we'll give them a script to PEP for PrEP, and then they can continue it the next day. Okay. So in the ACT, other than general practice, if the GP feels confident to prescribe PEP, as Clara mentioned before, once upon a time, all patients came to Canberra Sexual Health Centre, but they can access PEP at our service Monday to Friday, 9 to 5, or they can access it at an emergency department as well. And we've covered off the time frame there, so within 72 hours. Okay. So does anyone want to put in the chat box or the Q&A box, what HIV test would you order if you were starting someone on PrEP? Everyone's gone a bit shy. So we'd order the HIV antigen antibody tests. Okay, and I mentioned the window period before. So Australian labs use the 4th generation test, which becomes positive 2 to 6 weeks after the exposure. So it's generally recommended to test patients on a baseline at their initial presentation, and then 3 months later, except if they've had a recent high-risk exposure. And then we test them at a month, and that's what we do here at Canberra Sexual Health Centre. Okay, we've talked about signs and symptoms of acute infection, and we've talked about EGFRs. So that minimum EGFR for tenofovir disoproxil fumarate, which is the easiest and most common PEP prescribed, is an EGFR of over 60. And I'm sure you know much better than me examples of nephrotoxic medications, but some we will look out for, and some we will look out for in this patient cohort, high dose or multiple NSAIDs, aspirin, aminoglycosides, and we also look in this group about for patients on protein powders and protein shakes, because we've got a lot of gym users, and that can affect EGFRs as well. So I think we've talked about PrEP and Hep B. Is it safe? As we've talked about, vaccinate. A positive Hep B does not usually necessitate a delay in starting PrEP, but adherence usually with the daily dose recommended is very important. And we have covered off an on-demand PrEP there, but we will go over a bit about that. So in IPREX study, which was one of the big PrEP studies, in that nearly 2,500 participants, 12 people had chronic Hep B and 4 had acute Hep B, and there were no flares and no hepatitis B resistance to tenofovir disoproxil or emtricitabine. Okay. Any questions, please keep putting them in the box. So PrEP and pregnancy. A pregnancy test is part of the assessment, and the current evidence does show that PrEP is safe to use in pregnancy after informed consent, okay? Because it may be related to low bone mineral density, lower length and head circumference. We do put... if we have a couple where usually the male has HIV and might be well controlled on antiretroviral therapy and has a female partner who doesn't have HIV, we will usually start them on PrEP if she's planning a pregnancy, or if she does become pregnant, because that would be the worst time that we would want a woman to fall pregnant, a woman who is pregnant to contract HIV as well. So most of our patients in that situation are on PrEP. Okay, so a checklist prior to starting PrEP. I think we've covered off on this. Are they seroconverting, or do they have HIV already? We know their renal function's normal. Are there any co-infections we need to be alert to? Do they have another STI? Are they pregnant, or are there any possible interactions? And we've got there our over-the-counter PrEPs, NSAIDs and protein supplements. Okay, and there's a great interaction checker, which is the Liverpool HIV drug interactions. You probably have really good checkers on all your practice software, but it's a really valuable tool. And if you just Google Liverpool HIV, it uses a traffic light system, and it will give you levels of evidence as to whether there's any interactions between PrEP and any other medications. Okay, so I think we've talked about this as well. tenofovir, disoproxil, and emtricitabine, the same medication for different uses. So they are antiretroviral medications, PEP and PrEP. And we'll talk a bit about these long-acting injectables in a minute. Okay, so Descovy, that's the tenofovir, alafenamide and emtricitabine that I talked about before. Indicated for PrEP in at-risk adults and adolescents. We have quite a few patients on this who've over time had substantial decreases in the EGFR, or they might have pre-existing renal disease, and we've switched them to Descovy. It cannot be used. Descovy is not indicated to be used on demand. It must be used daily. And there has not been any good studies done in people with vaginas. And it's not PBS listed, as we talked about before. So patients do have to import it from overseas and be somewhat organised to do that. Okay, we've got injectable cabotegravir long-acting. So we're using this now, and I know Clara is too, as a, cabotegravir and rilpivirine, and this is just cabotegravir as a HIV treatment. This is a long-acting injectable agent for PrEP, where people have 2-monthly injections. It's fantastic, and this HIV Prevention Trials Network study found that it was superior to a daily pill in gay and bisexual men and transgender women, and that was because there were no missed doses. This cabotegravir long-acting has been TGA approved, but it's not yet PBS listed in Australia, but it may be in the future, hopefully. We've got a list of about...
Shannon, so there is a trial, a special access trial going on, where if people have got a contraindication to taking oral medications for PrEP, they can actually apply, for special access to injectable cabotegravir. As Shannon said, the HPTN study showed superior efficacy, but that was probably in an environment where taking regular oral PrEP is probably a little bit more difficult. And so it's, I think that, and so, because it's of its much greater cost to government, that's going to be the problem getting it PBS listed in Australia.
So we have about 10 patients that will probably apply for this special access, and that's been funded through the drug company, through ViiV, who make it. And one patient's had an allergic reaction. I think 2 of them have had an allergic reaction to PrEP, and then the other patients have deranged kidney function. So if you do have any patients that you think might be eligible for this, please contact us at Canberra Sexual Health Centre. From what I last heard, they've got 100 compassionate access, and I don't believe there's been much interest, surprisingly.
No, I don't think that there's been an enormous demand so far. So I think if you do know people who, for whatever reason, have got a contraindication taking oral PrEP, then this could be an option for them.
Yeah. And then in the future, there'll be this injectable lenacapavir, which is made by a different pharma company, but this will be long-acting, again, injectable, obviously, in 6-monthly injections, which is fantastic because one of the downsides to the cabotegravir is patients suddenly start having to come every 2 months. So 6-monthly will be great, and you can see there the really high 99.9%, and that Purpose 2 study, I think that was the one Clara was on, women in Africa, was it? No, that was Purpose 1. This one's been on men who have sex with men, and it's not yet TGA approved for PrEP or PBS listed, but that will probably happen in time.
Another great thing about the lenacapavir is that it's a subcutaneous injection.
Yes.
So it'll be much easier to take, whereas cabotegravir, unfortunately, is a painful intramuscular injection.
Yeah, it is. So this is just a calendar about our daily PrEP. So with this little star being a HIV risk exposure, that speaks for itself. And daily PrEP is preferred, has the strongest evidence base for all populations. However, there's certainly a place, and it's very safe and effective also to use on-demand PrEP. I think we've talked about how to take it and start it. So for cis men, they can take 2 tablets 24 to 2 hours prior to sex. They've just got to be ready. And otherwise, if it was a woman starting PrEP, she would take 7 tablets in a row for 7 days and then be covered. And again, for cis men, they could just take 2 doses to stop, or 28 days for everyone else. I think we've talked enough about PrEP and PEP, and that's our intermittent PrEP. And the drug, there's the link there. I won't open it because goodness knows what will happen, but you can just Google Liverpool drug interactions, and it comes up with the fantastic tool. Okay, what about side effects? What do we say to patients about side effects? Initially, patients may have them, they may be quite common. And we found from the big trials that it was usually reported in the first 7 days. It's got a month here, but a lot of patients do say it settles down after a week or so. With nausea being the most common, and we will tell patients to take it with food to try and alleviate that. Diarrhea, headache, fatigue and flatulence. We have very few patients stopping PrEP from side effects. Just general supportive measures to get through that period. And some patients who do get side effects can switch to on-demand if it's an option. But most patients get over any side effects quite quickly. We've talked about how to prescribe it, and it's a restricted benefit. Every pharmacy has PrEP now, and it's very commonly prescribed, as Clara mentioned before. Okay, so we've talked about that, the cheaper chemist costs, compassionate access programs such as through, well, that's through pharmaceutical companies, which is not commonly accessible now for the tablets because they're so cheap, but the compassionate access voucher scheme is available through Meridian. Or there's the PAN, that's the PrEP Access Now website that someone asked for before. Great, Kara's put it there. Thank you, Kara, for details and pricing. And a lot of our patients use that, and it really is very reliable. But, you know, it's not always suitable for everyone, especially if, I don't know, you live at home with your mum and dad or your wife. You can't have PrEP delivered to your house for obvious reasons.
Shannon, we got a question here. Can patients import oral antibiotics or doxy PEP from overseas?
Yeah, probably. They'd probably, because so doxy PrEP or doxy PEP, we're prescribing quite a bit of doxy PEP now, which is 2 tablets after an event within 72 hours. We do have the occasional patient who will take doxy PrEP, which is like 100 milligrams daily to prevent, within Australia, doxy PEP is to prevent syphilis and chlamydia, and maybe about 80% effective at preventing them if a double dose of 200 milligrams is taken within 72 hours. Has no effect on gonorrhea here in Australia because of our resistance, but it's quite effective against gono in the USA and the UK. Patients could import doxy from overseas, but again, they'd need a script to legally be able to self-import. We tend to write our script for our patient who's on doxy PEP. We'll write a script for 200 milligrams stat as needed, and we generally prescribe 21 tablets and 1 or 2 repeats, which is quite cheap from some of the cheaper chemists especially, or they could use that script to import it.
Yes, I mean, doxycycline is not an expensive medication,
No.
so yeah.
No. Okay, so just some tips about adherence here that we can talk about with patients. If you don't take PrEP, it's not going to work, of course, like your blood pressure tablets and everything else. Some patients will have the odd patient who will say they dose 4 times a week, and this was taken from IPREX, which showed that you could have 4 doses a week, which was usually Tuesday, Thursday, Saturday, and Sunday. And that was about 96% effective versus 7 days a week. So the more you dose, the better protection you have, especially if you're taking it 4 times a week and you accidentally miss a dose, which is easily done. And that adherence is more important in females. And every dose needs to be taken in on-demand PrEP for it to be effective. So adherence is key.
And Shannon, I think we mentioned a few times about the difference in PEP and PrEP, for cisgender men as opposed to other genders, and my understanding is that that's because the serum levels of the PrEP medication, the vaginal skin actually rises a lot more slowly.
Yes, that's right. Yep. Okay, I think we've covered this. Okay, and we've talked about ongoing management, which is on the back of the tool, mostly 90 days every testing, or 6 monthly renal function testing. So at a 3-monthly review, we check tolerance, adherence, any new medications or treatments. Do a risk assessment. Is PrEP still relevant for this patient? They might say, I haven't had any sex. They might be on daily PrEP, but have not had any sex or had a bit of a drought in the last 3 months. You can talk to them about whether they might want to switch to on-demand PrEP or do they still need PrEP. Perform an STI screen, renal function, see if there's any other harm minimisation that we need to go through, review mental health and any substance abuse. So gay men in particular have high rates of smoking, drinking and using other drugs. And then we've got our other Staying Safe needle syringe program, condoms. A surprising amount of people do still use condoms despite PrEP, and safe injecting. Okay, have we got any questions that anyone wants to if we wanted to unmute people, or if anyone wants to put any more questions in the Q&A box. Otherwise, we can move on to some case studies.
I think you've managed to attack the Q&A box pretty well, but please, if the audience do have some questions, type them into the Q&A box and Clara or Shannon will be able to monitor them and answer them as they come in.
PrEP is really easy to prescribe. It's really safe. And it means you can prevent a HIV infection in someone. So it's really important. So a group we haven't really talked about here is in this presentation is adolescents. So for younger men, daily PrEP is recommended. And obviously that everyone else who doesn't fall into the men category, daily PrEP is recommended. But if you see an adolescent, the recommendation is daily rather than on demand, because they haven't done enough trials on on-demand use in adolescents, but they can tend to be a bit forgetful. So the recommendation is daily PrEP in that group. All right, Clara, shall we do a case? We don't have any questions.
No, yeah. Well, I think we've actually gone through the questions through the talk,
Yeah.
So I guess we might as well do a case and we can discuss it with ourselves, among ourselves.
Okay. Cara's written, the renal function always throws me. Urine protein creatinine might be elevated, but EGFR is okay. If the patient has a history of GYM high protein, do you do a clearance to check it's a false abnormality? Yeah, we have
GYM high protein. Do you do a clearance? I'm not sure exactly what you mean by clearance, Cara. Urine, but so urine PCR can be elevated for lots of reasons. It may not necessarily be a Fanconi syndrome, because you could get elevated protein, from infections and other things. I mean, if the EGFR is all right, I would think it's very, very unlikely to be a Fanconi syndrome.
We have a number of flow sheets and boxes and things about what to do with renal function. If we had an elevated protein creatinine ratio, we'd often, if it's less than, just looking at the thing now, it's less than 40, I think, we just repeat it next visit. Otherwise, we might get them in and repeat it. Or sometimes we might tell them to stop taking their supplements for a while so we can redo it. Okay.
Sorry, more questions have come in.
Yes. What about insertive MSM condomless sex?
So in adolescents, considering compliance with the injectables be a better option? Possibly, but at the moment, injectables are incredibly... so of the two injectables that we mentioned, cabotegravir is only accessible cheaply through a special access scheme at the moment. You have to actually contact someone who's actually referring people for the scheme. So in the ACT, you can refer someone to the sexual health clinic or to me. And we would then actually have to fill in a form specifying the criteria as to why this person needs to go on the injectables, submit it to the drug company, and then the drug company has a review board looking at the submissions to approve it or not. Now, if you try to buy it on your own, it'd be very expensive. I actually don't know the cost off the top of my head, but I'll be guessing something like $900 or $1,000 per injection. Do you think, Shannon?
Yes. I think it's even, it would be about that, I think. Yeah.
So
it's pretty expensive.
So that would be for cabotegravir. Lenacapavir is just not available at all at the moment in Australia.
Yeah. Got another good question there about insertive MSM condomless sex. So if you're the top partners, because you're right, the guidelines talk about receptive sex, which is the highest risk, the receptive sex. But insertive condomless sex is still a risk, especially if you're uncircumcised. Or if the top partner's uncircumcised. So we would certainly still recommend PrEP in that situation, regardless of circumcision. Yeah.
And then the question before that, Cara, I think was in answer to my question about what do you mean by clearance? No, yes, I think if somebody gives a history of taking a lot of protein supplements, and typically what tends to happen is that their EGFR is artificially lowered, by their protein supplements because the protein supplements actually tend to raise the creatinine level. So if that's what they've been doing, I would certainly normally suggest they actually have a period of not taking the protein supplements and then check the test again. Do you agree with that, Shannon?
Yeah, definitely. And we say it, sometimes it doesn't go over very well with patients feeling that if they can't bulk up at the gym, they won't need their PrEP because no one will find them attractive, which is completely untrue. But we have said to a couple of patients at this point, it's going to be either PrEP or protein at this point. So you have to make up your mind. But they can usually reintroduce their PrEP supplements later too. Yeah. Okay, shall we go through this first case?
Yes, let's do it.
Because we've still got 15 minutes. So this is Adam. A young man calls wanting PrEP and begs reception for an appointment ASAP. The receptionist comes to you uncertain what to do. So he's begging for an appointment. Would you like...
If I got a case like that, Shannon, I'll be I think my first thought would be, has this person actually had unsafe sexual intercourse and actually want PEP?
Yep.
And so I would probably try to fit the patient in, because, you've only got a 72-hour interval to introduce the PEP, and if we delay this, we might miss the deadline and we might actually fail to prevent an HIV infection.
Yep.
Did you think, Shannon?
I would agree, definitely.
Yeah.
Definitely. We have some urgent PrEP appointments here because people have forgot they're going to Bali or something tomorrow too. But I think what you've said, Clara, is much more likely. Okay. He hasn't had a risk exposure in the last 72 hours, but he had unprotected sex last week that's been playing on his mind. He reports unprotected sex at least every month, often more commonly. Could you put me on PrEP now, please? So what could delay his request to start?
I think as we discussed, because he's we actually need to have an HIV negative
Mm.
test, don't we?
Yep.
Particularly since he's had unprotected sex, so he could very well be falling in that window period, and we don't really want to be starting PrEP, and have a serial conversion, and then he'll be developing resistance, to his medications, so we definitely need to get the test done. And I think, as we discussed, what we could do is that we can actually do his HIV and STI tests and hepatitis and other bloodborne virus tests, and give him the script and tell him not to start it until we actually get the results.
Yep.
But given that he's actually had unprotected sex last week, we'll probably have to get him back in a month's time, and in 3 months' time to repeat the HIV test as well.
Could I
Yep,
just
definitely.
interrupt and ask a question from the facilitator's chair? With the PEP, do you have to do the renal function and check for Hep B as well, or can you just prescribe PEP?
We would probably do the same tests on baseline if we were giving it as PEP. If you forgot to do the renal function, they're probably only going to take it for a month, and it would be far more beneficial for them to take PEP than not.
Right.
Yes.
Thanks.
Okay. So we talked about how to take his PrEP. Prevention messages, Clara's just covered that about window periods, and we'd see him again in about a month, or get a HIV test order for another month. Okay, this is Sam, who's a 32-year-old gay man originally from Vietnam, and now he's a permanent resident of Australia. He comes in seeking PrEP. He's got no regular partners, casual contacts through Grindr. He does have condomless anal sex. He's fit and healthy on no medications, non-smoker, and no alcohol. So what else would we want to know about Sam?
I think the thing that would that I would be thinking about first, is that given that he's originally from Vietnam, and and I think it reads like he grew up there, the thing that I would be concerned about would be chronic hepatitis.
Yep.
Mainly hepatitis B, but for people in Vietnam, there's also a significant risk of chronic hepatitis C.
Yep, sure.
So it's not that we won't give him PrEP, but we may need to actually check all those things first before we actually put him on PrEP.
Yep. So you would support his PrEP decision after you've checked out all those things?
Yes.
Depending on those results, yep.
Yeah.
And what if he didn't have a permanent residency or Medicare?
You guys can still prescribe PrEP for him, I think, can't you?
Yeah, definitely.
Yeah.
Definitely.
Yeah. So for GP, it is a little bit more difficult for us, because there's the question about the cost of the medication. I don't think that's, if I was in that situation, that and there wasn't any other way this person could actually access PrEP medication, then I might consider giving a private script. Might consider sending him to Meridian for a voucher. But the Canberra Sexual Health Centre does have a program where they do actually support people who don't have Medicare access.
Yeah. And there's going to be some money coming out soon for, because the highest number, as Clara mentioned before, the highest amount of people, new diagnoses are in people born overseas who may be Medicare ineligible and therefore are not accessing general practice or any services because they don't have the money to without Medicare. There's some Commonwealth money that will become available for patients like Sam to be given PrEP for free. So that's becoming available soon. And what baseline tests? Clara's talked about that. So he'll have the PrEP barrage, so HIV, syphilis, kidney function, chlamydia and gonorrhea, hepatitis B, hepatitis C, hepatitis A. Have I missed anything there? No. So we would do all those tests on Sam as baseline. Okay, so he's had these tests. There you go. So he doesn't have HIV. His creatinine's 93 and his EGFR is over 90. Syphilis is negative. Hep A is not detected. He's got a Hep B surface antigen positive and core antibody positive. He doesn't have Hep C and he's negative for chlamydia and gonorrhea. So what will we do with Sam? So
Well, we could, there's always a simple thing is that we could just refer him to a hepatologist.
Yep.
But we could also do further tests to find out a little bit more about his hepatitis B. So do a liver function test, check for his E antigen and his viral load.
Yep. Great. Okay, so for blood counts normal, his liver function, his ALT's 22. His E antigen positive and E antibody negative. He's got a high Hep B viral load. Normal coags, AFP and physical exam, and his Hep D serology is negative. So what would we do?
So he's actually in the immune tolerance phase, and if there's no sign of hepatic inflammation, or fibrosis, then he probably wouldn't need treatment at this stage, but it probably still be a good idea to actually refer him to a hepatologist or to a GP who's actually a Hep B S100 prescriber, because he will need to have continued follow-up. He doesn't need to go on medication at this stage, but he needs to be watched closely to see when his Hep B status changes, he starts getting flares, because that he would then need to go on the treatment.
Yeah, great. Thank you, Clara. And we've got a couple of questions. So Rosalie said we'd give a Hep A vaccine. Yes, we would, because he was not immune to Hep A and he has sex with men. And there's a question about starting PrEP. This is not a stupid question. It's a good question. Could starting PrEP within 72 hours of risky sexual exposure delay HIV detection and lead to a false negative result if testing is done around the 1 month window period? So we used to, with PrEP, we'd do HIV testing for 6 months, but I think they found that was not necessary anymore. There is sometimes some concern about false negative HIV results on people on PrEP. But we have not.
I don't think it's very. I think it's there. I think there have been cases reported, Shannon, but they're really very uncommon.
Very uncommon, yeah. So you'd still be very safe to do that. Start them on PrEP and do a HIV test. Okay, our next slide. So Clara started that. Refer to hepatology. Would we start PrEP? Well, we wouldn't ideally start on-demand PrEP because Sam needs treatment. Would you start PrEP, Clara, or would you wait till he's seen a hepatologist and he's having sex about once a week?
Yeah. I think, I'm not a Hep B as I'm prescribed anymore. I gave it up this year, but I used to be, so I think putting on that hat, I would sort of say, I would probably start him on PrEP, because his liver function tests are not compromised, so it's not a significant liver inflammation. But I think if anyone else is unsure about that, then probably send him to the hepatologist just to make sure.
So that's probably answered your question, Cara. So we'd start him probably here in the clinic on PrEP and refer him over to the liver clinic and talk to him about flares and adherence, and not to stop his PrEP on his own. His household contacts and sexual partners need Hep B vaccination, and we'd vaccinate him for Hep A, as you mentioned before, Rosie.
And I think especially in this young man, because he's actually got such a high viral load, if we actually put him on PrEP, it would suppress his viral replication. But then when you take him off PrEP, he's had a sudden burst of very intense viral replication. So that's probably a situation where it's likely to stimulate the immune response and cause a flare.
Yep. Okay, and we might have time for Jim. He's 52 and comes in for his primary care. He's off on one of his legendary yearly holidays to Southeast Asia with the guys. He has sex exclusively with young, pretty women, and he comes back to Perth with a bacterial STI and jokes about who among his friends has racked up the most STIs. Is there any place for PrEP for Jim?
Oh, definitely.
Yeah.
Just because it's actually having sex with young, pretty women, doesn't
Yep.
necessarily mean that there's no risk,
No.
And given that he often comes back with a bacterial STI, then he could actually be catching other things from these young, pretty women as well.
Yep.
And depending on which Southeast Asian destination he goes to, the young, pretty women he meets might actually be transgender women as well, and he might not even be aware of that.
Yep. So definitely PrEP for Jim. And then we've got Ben, who's already on PrEP and comes for his 9-month holiday. Oh, his 9-month follow-up. His HIV testing and STI testing are all clear, and his EGF 70. What would we talk about with Ben? He's 25, so he's quite young.
I mean, 70 on its own is not necessarily bad, but except the fact that he's 25, and you would normally expect someone who's 25 to have a EGFR to be over 90. And I think on the next slide, we'll see that EGFR is actually trending downwards. Oh,
Okay. Sorry, that was me. We've gone through all that with him. Adherence. That's the same patient, isn't it?
Yes, yeah.
STIs, harm in, adherence. Is he on any new medication?
Sorry, I've jumped ahead.
That's okay. We've got to jump ahead because we've only got 4 minutes left. So is he on any new medications or anything over the counter?
Yeah.
Is he still clinically suitable? At this point he is, because his EGFR is over 60. And we can see there 9 months. Yep.
So I guess with Ben, given I don't know whether we've mentioned talking to him about proteins and supplements, because that would certainly be one of the possibilities. But the other thing is that if that isn't the case, and then there are no other extraneous medications that might be causing the reduction in kidney function, then we probably do need to watch him very closely, because it's getting close to the point where we don't really want that EGFR to drop any further.
No. And this would be the sort of patient, Clara, that sometimes we will talk about Descovy even, because he's had a significant drop.
Yeah.
Okay. How are we going? We've got 2 minutes. We might have to skip Gary. Are there any more questions? Okay, well, we'll do Gary. He travels monthly to see a male partner. He has sex once a month or less. He tries to use condoms. He thinks his partner has other partners, really common. What do you need to know, and what should you advise? Hey, he only has male sexual partners. He never injects drugs. He's suitable to take PrEP on demand because he's only having sex occasionally. And that would be perfect for Gary. Okay, so take-home messages. PrEP's effective, safe, well tolerated, and easy to prescribe and take. Important to follow ASHM's 5 steps, and those ASHM decision-making tools are excellent. Assess their risk, clinically eligible, any other testing, prescribing, and ongoing monitoring. And you can always ask for help from an experienced prescriber. But PrEP's fantastic and has been such a game changer in HIV. So certainly everyone's role to identify patients at risk and get them onto PrEP, or if you don't feel confident, to refer them to get them onto PrEP. Okay, and there's some good resources there. The PAN address for importation, PrEP for change, the decision-making tools. There's a sample letter about writing about PrEP to GPs, dosing guides, and PEP information, and all that is, there's a QR code that can take you through to the ASHM PrEP hub. And there's this great ASHM site now that's new, all about PrEP. So if you want to go on there and have a look to reinforce, or if you haven't learned anything tonight, to learn how to prescribe, and you can access the site through that link. Any final questions? But you can always contact us here at Canberra Sexual Health if you have any questions. This person said they're discouraged from prescribing PrEP unless they have a longer term relationship instead of a script because they can't see the regular GP or some other inconvenience.
From my discussion, unless I have a longer term relationship, I don't think so. I mean, after all, Shannon, quite a lot of your patients are patients that come in and go, don't they?
Yeah, and we mightn't see them for 2 years. Sometimes we'll see patients that haven't been to us for 4 years, you know. We prescribe it very readily and very easily, and you know, our patients are always coming and going.
Yeah. I think the point we're making
to
is that
the next slide just to show the QR code for the survey just before too many people drop off.
The next slide, yep. Sorry, yep.
Thank you.
Yeah. So I think I would say, the take-home message is that there are these baseline tests you have to do, but you can do it at the same time, you know, at the first consultation when you see that patient, and then it's really just about communicating the results with the patient probably the next day, you know, to say that, you know, your EGFR is fine, your HIV test negative, you know, you can go ahead and start your medication.
Yep, definitely. So please, if you have the opportunity, please complete the post-webinar survey. But thank you, everyone. It's been great, and there's been some really good questions.
Yeah, I'd like to echo that. So thank you, everyone, for attending tonight. And thank you very much to Neil, Clara and Shannon for the excellent presentation. And as Shannon said, please complete the evaluation surveys, and CHN can email you a certificate of attendance, and it's 1.5 hours of educational activities, which you can self-report to your CPD home. And resources, presentation slides and YouTube recordings will be sent out and posted shortly, so probably over the next 2 weeks. Okay, thanks very much, everyone, and have a good night.
Thank you.
Thanks so much.
Thanks.